Thanks for joining us today. I'm Phoebe Nelms, and with me is Liz Hansen. And today we're going to talk about the evolution of QPP, how CMS is fulfilling on its promise to make this program dynamic, constantly ever-changing. We'll tell you about our learning opportunities at the end of the presentation, just what dates they are usually held on. And if you have a topic you'd like to suggest for us, we're welcoming those. So today, what are we going to talk about? We're going to talk about 2023, the QPP MIPS updates. What are these new things that they are trying to get everybody to adopt, which is called the MVP, or the MIPS Value Pathways. We're going to overview what that is. What are the benefits of being an early adopter of the MVP? How do you register? What's your eligibility? And then we'll share a few resources that are available on the CMS website. So as we move forward, what are CMS objectives for 2023 QPP reporting? Well, they want to promote more meaningful participation for clinicians and ensure that the policies continue to drive towards value and improved health outcomes for patients, provide clinician continuity and consistency while they gain familiarity with MVPs, and reduce burden and facilitate participation in alternative payment models. This is moving the program forward. So, the program, of course, for eligibility, it remains the same as it has been, having $90,000 in Medicare Part B charges, having over 200 Medicare Part B patients, and offering over 200 covered professional services. This year, you have to meet at least a performance rate of 75 points in order to avoid a penalty. So 75 plus. There will not be, unfortunately, an uptick in your payment adjustment for exceptional performance. 2022 was the last year for that. So we want to understand the scoring requirements and the weights of each category. As you can see, cost and quality are equal and nothing to report for cost. So as we move on, unless Liz, you want to jump in and say something about this slide.
I do want to say that this is the standard amount, and we're not going to spend a bunch of time talking about what happens when you reweight, but there is some serious shifts in the numbers when you take an exclusion from one of these components and they're reweighted. And again, we're not going to spend a lot of time on that today, but if someone needs some help with it, we'll be glad to help with the decision-making process for that.
Excellent, thanks. So, whew, this is a busy slide. Sorry, y'all. It just kind of recaps. If you don't get more than 75 points, then your result will be a negative payment adjustment. We want to avoid that. Absolutely avoid that. Because what would that do to your bottom line? That is quite impactful for many small practices.
Yeah, and that's what we want them. We want the practices to think about is, put a pen to it, put it on paper. What would it cost you? You know what you should have a good idea of what your Medicare reimbursements are. Take a pen to it, see what would happen if you lost 9% of that for a year. And then realize, of course, even if you're low, you probably won't lose 9%. You may be at 60 and you may only lose 5%. So figure out what it's worth to lose that revenue and to continue to lose it. Sorry.
No, don't apologize. That's the whole point of this slide, is to, help people realize what the implications are, what's the impact. I wish it were a little easier to figure it out though, Liz, honestly.
I know.
Yeah. But so we have harped on this ad nauseum from the beginning of the program, as when we realized that these things were going to happen, audits. And so part of our support has always been to help you be prepared, just in case you are randomly selected. And we've had the opportunity to help a few practices who have been selected for audit, and it's not pleasant. But if they're prepared, it's a breeze. So the notification as to whether you've been selected will come from Guidehouse, and it'll go to an email to your designated contact. So you want to make sure that information is up to date. You would absolutely hate to miss this notification and be, considered as blowing them off or ignoring them. And they can audit you. This was surprising to us initially when we found out. Even if you didn't submit, even if you had an extreme and uncontrolled circumstances exemption, since claims are being submitted, if claims are being submitted, then they could actually audit you on that data. So be sure to generate a detailed summary report for each of your measures and save that in your audit folder because it will not look the same way if you run that report in a few weeks, much less 2 years from now when you may be audited. If you don't know if you're coding the claims with measure data, then find out. And if in doubt, print them out and e-save them. Anything else you want to add to this one, Liz?
No, I have just been surprised with how many practices we've worked with who promised me they weren't coding claims for reimbursement or coding claims with these codes. And we found out that they were. And it's not unusual for the office manager, for example, to not know that the biller is still using the same old Z codes or G codes, or that they're using them for a different reason. And CMS doesn't care. If they see the specific codes, they're going to consider them reported. That doesn't mean that they will make that they're going to erase the EUCE, but they're still going to audit you, or they still can audit you. So this is a real shocker. It's actually, I believe, contrary to what they first told us. So I'm very concerned with it, and I want folks to really pay attention to this because we had a lot of folks taking extreme and uncontrollable circumstances. And if you took one last year, I recommend you go print those reports out now, just in case you get audited in the next few years. So this one bothers me. Thanks.
Yeah. So in line with that, we want y'all to be prepared. And one of the best ways to do that is to check the data validation documents that are available in the resource library for each of the categories that you have to report. So review this data validation requirement, especially for your improvement activities, and make sure that you have documentation that you've actually performed the improvement activities, and whatever that guidance is in the validation document, make sure that you save those pieces of evidence pretty much. Particularly pay attention to column F, where they said, okay, this is how you can meet this, this is how you can document this is what will satisfy the requirements. And now we have this kind of detail available for promoting interoperability. For the longest, it was only available for improvement activities. And of course, the quality measures had their measure specification sheets with all those details. But good resource to take advantage of. Liz, help me out with this one here.
Okay, so this is an example of the new data validation sheet for promoting interoperability. And it was just way too much, just like the other, way too much to put on, really to put on a screen to share. But I just wanted to show folks how it takes one measure, electronic case reporting, and it tells you what you have to do on the far right in that far column. It tells you what you have to do to prove that you met that measure. And all we did was just put that underneath so you could see what that last column, A, B, C, D, was that column F? Yes, you could see what column F was saying for this particular measure. But the point is, these specifics are available for every promoting interoperability measure, just like they have been for improvement activities. And we need folks to read them at least once a year, twice a year, just in case you fell asleep the first time. We need folks to go look at these.
Yeah, so usually when they find a resource provide a resource in a couple of years, you might, realize why you needed to pay attention to it. They may not tell you up front.
Well, and we saw improvement activities that nothing would change except the column with the validation requirements, and that did change several times. So we know you got to look at this every new year. You got to look at the new document just to make sure somebody hadn't changed their mind.
Good reminder. And so another good reminder, you must report for electronic case reporting for the PI component in 2023. I think it was optional last year, but it is required this year. So ask your EHR vendor to provide the status of their capability to do this in writing. You can register without being in production for 1 year only. And the Georgia Department of Public Health has an effort in progress. So get registered before your submission date range begins for PI so that you'll meet the requirements for that reporting period. Anything else on this one?
Well, we hope this is going to open up any day now. I've actually had people go ahead and fill out that old form for registries and submit it to DPH, and we were hoping they were going to come back and say, we can't take this yet, we're still working on it. And instead they came back with just some information about how this was gonna be good going forward, but no dates and no instruction on what the practice needed to do. So I told them just to tuck it away, to step back, and we'd give them another month or two and then try it again. Because we don't really know what the process is for registering. So we're trying the process that we used for syndromic surveillance.
Okay. Yeah. There's a lot of information on the CMS website, but not, about what it is, but not necessarily how to do it.
Well, and that it's a state by state. Okay, so
yeah, and EHR vendor by EHR vendor, their readiness and their
exactly. So
integration.
If you go on DPH's site, it literally says in progress, right?
Mm-hmm.
So, but the thing is that's okay. We just needed proof that we've tried to register and they've responded. So I feel like those folks that have done that
are safe.
Are pretty set for this year, but I'll have them redo it if it opens up.
Awesome.
So, yeah, just an idea for folks to pursue.
Awesome. Well, I am going to hand this whole thing over to Liz to talk more about MVPs.
Well, thanks,
Liz.
Don't go anywhere though, right?
Oh, I'm not going anywhere.
Yeah. So we're going to talk a little bit about MVPs today. And CMS has said that MVPs, MIPS Value Pathways, is the future of the quality payment program and how they are going to reimburse for Medicare. Before we go any further, I just want to say right here, right now, join an ACO if you can. And that should tell you lots. All right. So, but let's just talk about MIPS Value Pathways and how they came about. So the objective was to come up with, I don't know if any of you folks remembered when we had meaningful use, and some of our providers used to call it meaningless use, or they had some real cute things to talk about, meaningful uselessness and all kinds of things like that. And so CMS was listening. All right. I know folks didn't think they were, but they were listening. And so they're still listening, and they've been trying to come up with a way to measure, because they got to measure. I mean, we've proven that we don't really move forward too much. We got to have our carrots and our sticks, right? And in our industry, apparently. And so we've got to have a measure in it, but we want to make it where it's beneficial to the provider to have these measurements and not just hoops they jump through to satisfy CMS. So that's one of the objectives, to have the continuity and consistency while you gain familiarity. That's one of the objectives. Reduce the burden and facilitate participation in alternative payment models. That's the goal. And I would say to you, the sooner you do that, the better, because you'll have people taking care of you or guiding you on how to do this. And you'll be your numbers will be averaged in with a large group. So the pain is not as bad. And oftentimes, there's rewards. That was my commercial, I guess, for ACOs. But anyway, MIPS Value Pathways has really just been talked about for the last couple of years, but now it's here, now it's available, and you can participate in 2023. Yeah, you can participate as individual clinicians, single specialty groups, multi-specialty groups, subgroups, APM entities, lots of ways to participate. And CMS has now included 5 new categories or MVPs available to practices and revived 7 of the original. So there are now 12 MVPs available. And they're not going to stop with that, folks. And we know that this doesn't even touch the surface of what a lot of especially specialists need. But it's a good start and it's a good base. And we need you to look at it and see if there's any way it can apply to your practice. And now, if you look over on the right, you'll see that we've got a graphic that says that the foundation of all MVPs is promoting interoperability. So regardless of which of the 12 you picked, you would have to do promoting interoperability in all its glory. All right. And we've talked about promoting interoperability. We're most familiar with it, I think, because we spent so much time with it when we were doing the so meaningfully useful measures from before. So, foundations promoting interoperability. There will also be population health measures. Got a lot of interest, a lot of stimulation around social determinants of health. Wouldn't be surprised to see some health equity measures come into this in the future, but that's your foundation. Okay, and you want to be able to make sure that you can track what you do and you understand what you've got. Then we have the upper portions, cost, quality, improvement activities. These change. They change with the MVPs. So that they don't just change for the goodness of changing. They change to be customized to the specialty or the environment that you are in. So this is a good thing. We just got to work on getting some more flexibility with our quality measures. But this is a good thing, and my colors work. I'm just saying. All right. Why are we in this MVP situation? Well, we had a lot of folks being successful with the quality payment program, but it wasn't really being as beneficial to the providers nor to patients as we would like. So the objective was to simplify the clinician experience, not have to keep up with as many things, streamline it, reduce the set of measures, improve the value, not improve just the value as in the cost of the reimbursement or the cost of the services, but the value that it brought to improving people's health, the value that it brings to relieving the burden from providers, reduce the burden, and to better inform patient choice in selecting clinician. Now, I'm going to stop here for you for just a minute. Not real clear to me how this is going to be different than regular QPP. Phoebe, if you've got some insight here, I'll take it. But
well, it's supposed to be less confusing.
Okay. All right. I can deal with that because a physician compare is still going to be, I think, what patients can use to see what the situation or how their providers are doing. But I would submit to you that most patients don't know how to use physician compare and don't understand what the number means and don't understand the components. So yeah, okay. So I'm still on the fence with this one. I'm sure by next year, Phoebe will have convinced me. So MVPs are here to capture a patient voice and a clinician voice. And I'm interested how we're going to do the patient voice, but I'm sure there's going to be more to come. Or I'm afraid there's going to be more to come. So why EVPs in response to clinician feedback? And we have had a lot of clinician feedback over the year, and it's been very clear. But we rarely have feedback that gives us any way to tell CMS how they can improve it other than reduce the requirements. So this is what we're trying to do. A lot of providers are concerned that MIPS didn't allow for differentiation between performance in different situations with practices that had some quality measure selection bias, and we found that that has been true. The intention is to focus on the future of MIPS, and that future is going to be MVPs, hopefully more specific MVPs, and hopefully dragging the EHRs kicking and screaming along with us, because I feel like they're the component that are a little out of the loop on this. And the plan is for MVPs to be the only method of participation. Okay, so you would have to be in an MVP and have chosen that route to participate in MIPS, or if you're eligible and don't, you will receive a negative 9%. So that's so exciting. All right, so here we are in 2023, and we can begin voluntarily submitting through MVPs. When I say you can volunteer, that doesn't mean it won't count. That just means if you're eligible, then you can use this method this year. If it were me, I'd rather wait and let some other folks experiment with it for a year. But there are some benefits to doing it this first year. And the sooner you go ahead and, start eating on this, the sooner you'll be able to understand how to enjoy it. Nah, that's probably not true, or at least to consume it and digest it. So what we have is until 2026. If you're a larger organization, you've got multi-specialties, they plan to require mandatory. They hope to require it to be mandatory by 2026. Still sounds a little iffy about whether it will be. But that's what our timeline is telling us. And so we've got a lot of time, got 3 years. That's not a lot of time when you need your EHRs to catch up with you. So one of the things that I take away from looking at this timeline is I need to get on this bandwagon now, see if there's an MVP that works for us as a practice, and then approach my EHR to see if they have these quality measures in this EHR. Because if they don't, then this whole thing becomes very burdensome. And a lot of EHRs don't have a lot of quality measures. As a matter of fact, very few have, if any, have all of the quality measures. Wish that was the rule, but it's not. So let's try to get started today. See if we can't focus on a specialized path for us to do the quality payment program. And let's get familiar with the program. That's what Phoebe and I are doing. We're trying to get familiar with the program. We need some folks to get with it so we can learn it a little better from the inside, because all we can do is read about it until somebody actually gets ready to do it. We still need a case practice, use case practice, don't we, Phoebe? Or they need to give us an imaginary practice to play with to do this. So just understand the future of MIPS is to end traditional MIPS as you know it today, and for MVP reporting to become mandatory. Okay.
And because we don't know exactly how much more time beyond, what they say that we have, it really would be great to get some practice in doing this and to really be the squeaky wheel. We found that in some cases, the practices we work with, they really motivate their EHR vendors to get on board with making what they need available in the system, and it takes some time. They need some lead time to get up to speed. So if enough of their customers are squeaking, they're more likely to get on it, and that helps everyone who uses their system.
And that's 100% correct, Phoebe, and such great advice. If you're in a user group, y'all start talking about this, okay? Because you're going to have X number of quality. You got to have some quality measures. You're going to have a list you can pick from. Tell your vendor, because they're going to probably prioritize on their most users that are complaining. So please do that. The goal is, I keep talking about objectives and goals, and it seems like there's a million. But what CMS was trying to do is to align the categories in MIPS to complement a specialty. Okay. And so although there's still 4 categories, they should be more customized to the specialty or what your practice is doing. It does incorporate a set of administrative claims-based measures. Not everybody has to do them all, and that's one of the beauties of this. Not everybody has to do everything. You find an MVP that works for you, and you focus on doing those requirements. We've got 12 to choose from. I'm not quite sure how CMS chose those 12.
Probably a lot of analysis went into it, but not that we would have insight into.
Maybe there were some squeaky wheels.
Yeah.
There were probably some squeaky wheels because some of them are a little odd.
Medical associations and whatnot.
Exactly. And a few of them seem odd, but are in sync with other payment efforts, value payment efforts that, combined payment programs and such that CMS is doing. So although the joint and hip replacement seems a little specialized, it's one that CMS has another program that complements that. So that kind of makes sense. But we have a subset of measures. We have activities to look at. We're going to look at an example. It's kind of scary, but we're going to look at an example in just a minute. But first, let's go over the format. Now, at the foundational level, we see that we've got promoting interoperability. Okay, so we know we've got to do promoting interoperability, and we know that there are population health measures. And we do think those will change over time, right? The population health measures should reflect what's going on with the population. We certainly hope there'll be some improvements in the health situation, especially where we're seeing health equity. And so we could see these change over time. So in addition to your foundational level with your promoting interoperability, you're going to have quality, and you're going to have use 4 measures, and 1 measure must be an outcome or a high priority measure. If it applies, an administrative claims measure that is outcome-based may be selected. So there is some flexibility there. 4 quality measures. It's really not just 4 because of the claims-based measures, but 4 of the ones you have to pick off the big pick list, if you will. And so hopefully that'll be easier than 6. Hopefully. You can 2 medium-weighted improvement activities or 1 high-weighted improvement activity, or participate in a patient-centered medical home for your improvement activities. Folks, we really feel improvement activities are super productive, super easy, and a super way to get points. Okay, so what we're trying to do here, though, is do an improvement activity that complements your specialty or the efforts that your practice is committed to. That's the difference here. And then cost changes with each of the MVPs, or often is different for each one of the different MVPs. And so when we look at our example, we'll see which one applies, what cost measure. You may not even have a cost measure, or you may have a 0 in your cost measure, and that's okay. A lot of flexibility here on the surface. We haven't been able to get underneath the surface, but we hope the flexibility is true. Okay, maybe I'll ask you to do this daggum slide because you came up with it, and it's an important slide. It's one of those kind of things we would have missed if you hadn't found it, and we need to make sure it's in all of our presentation because you have to do something very different with MVPs. You have to register to participate in an MVP, and you have to do that between now and November. But you also have to have a very specific MVP ID. And depending on how you submit your measures, you have to put that ID in a different place. So we're just going to kind of go around clockwise and talk about each one of those just very briefly. If you're a small practice reporting through claims, and the reason it calls out small practice is large practices can't submit quality measures through claims, all right? if you are submitting quality measures through claims for your MVP, then you have to make sure that your MVP ID is on at least one claim. Now, apparently, if you put it on just one claim, then it'll be in the system, and you don't have to append that information over and over again. I think that I might, because it kind of scares me. All right. But in our presentation, we've got a link, and it has a quick start guide, and it talks to you about how to do this. All right, but that is usually what I find is the folks that are filling out the claims are pretty good about all the codes and all the data they got to put in all the different places. But this is new, so it can be easily forgotten. We've got to make sure this happens. If you're an MVP participant and you're submitting using a QRDA3 file when it's time to submit in 2024, then you have to make sure that you've got your identification number on those file, on the file. On
Everyone.
every file. That worries me a little, because
Yeah.
the QRDA3 files I've seen were automatically generated. So it tells me that the EHR has to have a way to put your MVP ID into the QRDA3 file.
Therefore, the November deadline to have made a selection of which one, so that you can share it with your EHR vendor so that they can then generate the file and include the number.
Yeah, unless we could put it in the name, and that would count, but I don't think so.
Oh, that'd be a good idea, to include it in the file name when you rename it.
If I didn't have another option, that would be what I would choose. But I think it's got to be embedded in it, Phoebe. I don't think it can be in the name. I think it has to be embedded in the QRDA3 file. So, got to do it. If you're third-party intermediary, if you're using a registry and they report for you, they have to have your MVP ID in every submission. Okay, and so you got to stay on top of this. You got to make sure you inform them in writing. You know, we're big on putting it in writing and keeping a copy, and make sure that they acknowledge it. And then if you're manually attesting, so that, let's say you've uploaded a QRDA3 file with your MVP ID on it, and then you're going to type in your promoted interoperability, and you're going to type in your improvement activity, there will be a way for you to put your MVP ID on those screens somewhere, but we don't know yet. We don't know where it'll be exactly yet, but it's going to be there somewhere. Is that your interpretation, Phoebe?
Yeah, that makes sense. So it says that if you don't add your MVP ID to whatever you're submitting to them, then you'll be scored according to traditional MIPS. And since the requirements are slightly different for traditional MIPS versus MVP, you may not score as well on MIPS if you unintentionally submit to MIPS and not the MVP, because it requires more measures and so on. So the devil's in the details, as usual.
That's a good point, Phoebe. And what'll nail you are the quality measures, right? If you only submit 4 and you were supposed to have 6, ouch. Big ouch. Big ouch. So let's make, and we'll remind you over and over and over again. All right, let's continue talking a little bit about the scoring. For the measures that are calculated through administrative claims, they're going to be calculated and scored at the tax ID level, not a subgroup level. All right, so if you have a subgroup, then those administrative claims measures are going to be calculated at the master or the 10 level, if you will. And so this kind of switches us, because now we're going to talk about, remember, CMS wants you to use subgroups if you're multi-specialty. And so we're going to try to talk about straight MVPs and your subgroups at the same time, just so we're not going to be here for 2 hours. If there's no group score available, then each measure will be excluded from the subgroup's final score. So it gives you It does give you some benefits of the overall practice, and it gives you the opportunity to be more specialized and pick measures that work for you with a subgroup. Okay, so there may be benefit for your practice in a subgroup. If you are multi-specialty, you have less time. They're going to make y'all do this, or they've stated they're going to make you do this sooner than later. And so let's try to figure it out. For quality performance category, outcomes-based administrative claims measure in an MVP, subgroups will be assigned to the affiliated group score. Now, again, that's at the 10 level. Okay, so even though it feels like a subgroup might be a scary thing, the place where we're going, most of its measures can default back to what the practice is doing. All right, so that's a good thing. What we don't want it to do is to default to traditional MIPS because we left something out. On cost, you're going to be assigned the affiliated group's cost score. Okay, so sometimes you will be on some of these components. You'll just be dependent on your subgroup score, but oftentimes you can take advantage of the group score for the MVPs. Now, if you don't have a subgroup, you're thinking about it just like you did traditional MIPS, but you don't have to do as many measures, and you can pick measures that work for you. Okay. It's just if you're a multi-specialty environment that this gets a little tricky, because then we got to use more than one pathway. Only one for each provider, but you may have 5 providers going down one path and 5 going down a different path. And so that's where we just have to manage that carefully. All right. Talk. What are they? All right. I'm going to do the ones on the right first because they were the older ones and they've been revised and finalized. Advancing care for heart disease, coordinating stroke care to promote prevention and cultivate positive outcomes, advancing rheumatology patient care, improving care for lower extremity joint repair. That's the one that seems a little very specialized, but it's in sync with another effort that CMS is doing. Adopting best practices and promoting patient safety with emergency medicine. And patient safety and support, and I can't read the bottom one.
Of positive experiences with anesthesia.
Okay, yeah, that one is real specialized and interesting. But most folks like their anesthesiologists, so they probably will do that one. But that one seemed a little out there for me. But folks, I got to tell you, the anesthesiologists have had very few measures available to them for 13 years now with this program. So it's about time those folks got a break. So I'm okay with that. My problem originally was I wanted more. I wanted some options for our primary care providers. Okay, so let's look at the ones that were introduced in 2020 for 2023, and we've got advancing cancer care, optimal care for kidney health, optimal care for patients with episodic neurological conditions, supportive care for neurodegenerative conditions, and promoting wellness. Yay! Okay, so promoting wellness, folks. That's our primary care one. Everybody could do that one if they wanted to, right? Everybody needs to be promoting wellness. But let's just take a look in a minute on what that one is like. Phoebe, did you have anything you wanted to add with these?
Oh, no. Just looking forward to how they will continue to expand this catalog.
I know. And they did expand. Okay, so I've got some faith there. Let's just go over this step-by-step piece here, because I think this is a nice piece. So again, registrations between April 3rd and November 30th, 2023. At the time of registration, individuals, groups, and APM entities will select one MVP for reporting, and one population health measure included in the MVP foundational level, and any outcomes-based administrative claims measures for the quality performance category. That's at the time of registration. At the time of registrations, subgroups have to select much more. One MVP for reporting, one population health measure that's included in the foundational layer, any outcomes-based administrative claims measure, if applicable, for the quality performance category, and a list of clinicians, MPIs to be included in this subgroup, and a plain language name for the subgroup. I have to tell you, every time I read that, it just kind of tickles me. What are they thinking people are going to try with this? I just
Oh, some computer jargon. I don't know.
I just thought that was interesting because the description of the composition of the subgroup. Okay, none of it's super hard. It just requires just a little forethought.
And doing it within the deadline.
Oh, yeah, and doing it within the deadline. Well, maybe we shouldn't have even put this November 30th here. It's like, hey, go. Right? The starter's gone off. Let's go. We do have plenty of time, but you need to think on this. You don't need to make a fast decision. You need to see if you need to make additional investments in your EHR to be able to do this effectively. So you need to look at that return on investment. The sooner you're able to do it, the better, whether you choose to do it or not. We really want y'all to be able to do it. And then we'll pressure more on the actually doing it later. So this was the Promoting Wellness MVP, or is. And it begins with the 2023 performance year. And it says we, that being CMS, not Phoebe and myself, we considered measures and improvement activities available within the MIPS inventory and selected those that we determined best fit the clinical concept of promoting wellness MVP. Okay, so who do they think should use this one? Preventative medicine, internal medicine, family medicine, geriatrics. Okay, probably could add rheumatology, but they kind of got their own thing going. And then you get a key. Isn't a big deal. The key just tells you, hey, if it's a new measure. New measures matter for us with quality, right? A brand new measure, you get a minimum of 7 points. So we're loving that if your system has that new measure. So we just got a little key that tells us how to work through it. That we have the information for you to go look at the document that has the MVPs, all 12 of them, and has all of this information for all 12. We just went and pulled out the promoting wellness one. So what is this? It looks like a lot, and it was supposed to be easier, but all this is the foundational level with promoting interoperability that everybody's having to do for all of the program right now. No different. And folks, you guys are doing a great job with this. You are really doing a great job with this. We would like you to improve some things. Yeah. I'd like for more of y'all to be on a health information exchange instead of chasing down direct addresses and getting so frustrated with each other. I'd like for everybody to be on an HIE. We'll keep working on that. I'd like it if everybody had their electronic case reporting figured out, but hardly anybody does. So stay calm. It'll be okay. But this is no different under MVPs as it is for traditional MIPS. So you're all good. You got this. Also, we have population health measures. We have a hospital-wide 30-day all-cause unplanned readmission one, or we have a clinician group risk standard hospital admission one. You need to do one. If you have no data for either, then an adjustment will be made. Okay, so it's weird for us to see a Q measure in the foundational layer, but CMS is aware, as is state Medicaid aware, that we have to improve health equity, and we have to understand what our population health looks like in order to improve it. So these are critical, although somewhat unpleasant. All right, Quality measures. Look at all the quality measures. Are they real different from anything you've done before? Probably not. But 4 of these will work for you. So pick out 4 and go make sure EHR can do them, and then do your very best to maximize your score on these. Now,
And would you, in line with that, maximizing your score, would you recommend checking out that benchmarking
that's
document?
exactly what I was going to say, Phoebe. Pick your favorite 6, and then go look at the benchmarks on them. If they top out at a 5 and you can't get more than 5 points for them, that might not be the one to use. Like documentation of current medications. Unless you're at, well, the net of it is it's hard to get better than a 7 on that one. All right. So let's pick your favorites, and even pick the 6 that you got on your system. If you've got 6 that you like and that apply to your practice, and then go check the benchmarks and see which ones have the greatest opportunity for you to make a good score. Then find out what the specs are, figure out the workflow within your EHR, and start increasing your numbers. Okay. If you only have to work on 4, that's way better than 6. All right. And if the 4 that means something to you, that's where you want to be. All right. Now you see some that we've seen so many times. Osteoporosis for women. We don't see many people doing that one. Breast cancer screening, yes. Colorectal screening, yes. BMI, yes. We don't see as much screening for depression. And I think it's because this particular one requires the follow-up plan. But we do feel like this could have a great impact on health. So we'd like for folks to consider that one if it works with your organization. Maybe your organization is really gearing up to start working on whole health. And so you're starting to do this. And so that would work right in sync with what you were planning. And then you could pick up an improvement activity to go with it. Cervical cancer screening, tobacco screening. That one's usually hard to get a high score on, but it is it in its 2nd year now? Might be in its 3rd already. CAPS for MIPS clinicians. We need to point out to you that if you're going to do the CAPS survey as a subgroup, your deadline is coming up the end of June. So if you need to, not a lot of folks that we work with, small practices and rural typically don't do the CAPS survey, but if that's something you do and you have some concerns about your deadline, let us know and we'll point you in the right direction on that. But your deadline is June 6th if you want to use the CAPS survey for a subgroup. And then we've got unhealthy alcohol use, screen and brief counseling. Got some really good ones here. We've got some new ones here. So we'd like for you to take a look at them. Adult immunization, I think that's a new measure. So, and see which ones are in sync or apply more to what your clinicians want to focus on. So what that really means is don't do this by yourself. We're going to talk about that in just a minute. Improvement activities. So these are improvement activities that CMS felt went really well with promoting wellness. Okay, so and we've used a lot of these in the past, so we like a lot of these, and we have some new ones. Promote use of patient-reported outcome tools. That one's not real popular yet. Might put that one on the side for right now. Implementation of improvements to patient portal. That's a great one, and even you may be improving that portal so you can have patients report outcome tools. All right, but remember, they're supposed to be able to interact with your portal through their API, so they ought to be able to report. So either of these should be able to work. Evidence-based aids to shared decision-making, unhealthy alcohol use, practice improvement of bilateral exchange of patient information. Like that one a lot. the 24/7 access to MIPS eligible clinicians. Love that one. And a lot of our practices do that one. Pick the 2, medium or 1 high that works best with your practice or what you've decided to focus on in 2023. If we had our way, we'd ask every practice to focus on 1 improvement every year. Really focus, not just to check a box. And then we've got the cost measure. Cost measures differ for each MVP. For this particular one, it's the total per capita cost. That's it. That's it. In traditional MIPS, what are we up to? 22 different cost measures or something, Phoebe? I don't know.
Not sure about that.
A lot. Okay. Well, it started out simple with just 2, and then it went to 4, and then it went to 6, and most of them don't apply to everybody, but it's still scary because you got to figure out, you got to make sure that they don't apply to you. So this one's very simple. This one's pretty healthy, and we'll see if you have patients attributed to you. That's what I'm interested in, how this one works. And that's why it probably wouldn't work if you weren't a primary care, because you wouldn't have patients attributed to you, so you wouldn't have a cost number. And that's why cost changes for every MVP. Sometimes we work these things out in our heads as we go. All right, subgroup registration and eligibility. So you do have to register as a subgroup. We're going to provide this information to you. You do have to use the plain language name and list. And I think we've gone over all this in that graphic form, and it probably looked better that way. However, I just do need to remind you, subgroups for CAP, using CAPS for MIPS survey, you got to be registered by the end of this month. That means you don't have much time. That means you don't have much time. And you do have to have at least 1 eligible provider in the subgroup to create a subgroup. So that is another piece that's important. The rest of it is really pretty straightforward.
25 cost measures.
25, what did I say, 22? Yeah, I mean, it just keeps getting bigger. Most of them don't apply, but there's a lot of them. So there are some nuances to the program. If you join as a subgroup and you're using your 1 eligible provider to justify the subgroup, then that's going to be what's applied for the 12-month segment. Even if that provider becomes ineligible, they're going to lock in that eligibility. And so that's a little different than anything that we've seen with MIPS. It's not that different from what we've seen in the past with other programs. We do want you to remember that multi-specialty groups are going to be required to form subgroups in 2026. Folks, that's 2.5 years away. That's not long. We need to figure this out for you that have subgroups. I mean, multi-specialties, we need to help you figure this out this year so you can experiment with it next year so you'll be ready when you have to be ready. So we just need to have a plan and start educating. You can include providers that are under the low volume threshold in the subgroup if you do have an eligible provider in that subgroup. So there are some nuances, and I am sure there's going to be some more because we haven't really done any of them. So we haven't started asking questions yet, Phoebe, right? We haven't really asked any hard questions. So this will be fun. Participation is limited to clinicians reporting through MVPs or the APM performance pathway. You can't, if you're not eligible, you can't do this voluntarily. You don't have the opt-in option or the virtual group options like you do with traditional MIPS. All right. I don't have anybody that's voluntarily reported or opted in or is in a virtual group. I haven't worked with anybody that's done any of those things. So maybe someday I will, but if it's a subgroup, you can't do those. Subgroups inherit the eligibility and special status determinations of the tax ID number group. Okay, so that's good. You don't have to figure out something new. And the 10 has to exceed the low volume threshold if you're going to do it at the group level. That's nothing new. That's similar to what was already going on. Subgroups don't get evaluated like a group does for meeting the low volume threshold. If the group meets it, the subgroup is included. Oh, I missed something there at the bottom. Phoebe, can you read that?
Oh, no subgroup scores for administrative claims measures, PI or cost.
Yeah. So that's great. Woohoo.
Might be an incentive to do it.
Right. Exactly. Now, what do you need to do? What's your checklist look like? You need to identify what MVPs will work for you and for your clinicians, for the practice and for your clinicians. Identify subgroups if that's something that might work for you or you have to do, and then ensure your eligibility. We don't want you to do this in a vacuum, though. We need you to talk with your providers. Pick your 4 measures. We've talked with you about this. Look at the benchmark, do your research. Look at the case minimums, look at data completeness. Talk to your providers about what quality measures they appreciate or more relevant to their practice. Communicate, ask, and then try to be able to do that. And then improvement activities which go with your practice. And I think improvement activities are going to be very simple for everyone, but it is a pretty slide. We've talked about the benefits and we're running out of time, but we do want to say to you that the best benefit for doing it now is it's new. CMS tends to be more flexible as we're figuring out these things the first year. It will probably be more strict going forward. So take advantage of it if you can, at least by 2024 if you can, before it becomes mandatory. Make sure that you can do it, okay? And I believe we talked about all these others. Yeah, I guess I could say them 6 times and still be the same meaning. What should you be doing to prepare for your transition from multi-specialty practices to subgroups? You've got to start looking at how those subgroups can be represented. And you got to do that by looking at the 12 available MVPs. It may you can have 2 subgroups and you got to lump everybody else over into the main group. It's something we got to talk about, something you need to research and determine, and it's new. So take your time. We talked about figure out what will get you the highest score, because that's still what we want to do, and how you should do it. Determine what your options are. Continue to improve quality and promote interoperability, just like we always tell you to do. Continue to improve. Look at getting into a registry. See if there's a good return on investment for that. That can help you because they will have more measures available, more quality measures available. But a registry doesn't answer everything. So don't expect it to. Understand what the benefits are. Manage your expectations. Have an internal meeting with your staff to discuss the importance of MIPS in 2023. And make sure that you talk with your practice leaders and your clinicians about the impact, the cost, the benefits of doing an MVP. You need to be having that conversation before the end of this year. Before the end of this year. Get the right tools in place. Make sure your EHR's got the measures you need. Make sure you've got a submission platform. Join a registry if you need to. Do what you need to do. Hire some consultants if you need to. Get on a health information exchange because you need to. Go ahead and start. Let's get these things done. All right, let's go ahead and start making things happen and start acclimating ourselves to this effort so we'll be able to do it. You've got the time, do it now. So we have some resources available to you. Probably the best is the implementation guide. And you can get it on the QPP resource library.
I just stuck the link also in our chat.
Okay. And Phoebe, I'll hand it over, see if there's anything else you wanted to mention on this. And
Oh, let's see. You have safer guides there, which is also a good reminder for the PI category. It's a requirement. And of course, always you can check the resource library for the most current available guidance. This is one thing that I love about the QPP, about the Quality Payment Program, is that the website is so easy to use. It's so searchable and they update it regularly.
Okay.
Upcoming webinars. We haven't chosen our topic for the next one yet, but we will definitely inform you of what our next topic will be. And please feel free to, next slide, reach out to us if we
Yeah,
can
and
be.
I wanted to say, Phoebe, we've had some really good, not necessarily technical webinars that I know the folks I work with really appreciate. And so we'd really like folks to tell us what they want to hear, because Phoebe and Carmen and Selena, they've got a lot of experts out there, and we'd love to share that expertise and that knowledge with you. So let us know.
Awesome. Thank you, Liz, as always, for wonderful coverage and partnership. I hope everyone has a fabulous rest of the day and stay well.
Thank you, Phoebe. Y'all have a good one.
Bye-bye.